This evening I'm going to be talking to you about growing a program of research in organ and tissue donation and transplantation from seed corn to naseberry tree. Now, the seed corn I have always thought of as my PhD work, which laid a theoretical foundation for the program that's followed on. The naseberry tree is a representation of where I am today. But I've got to tell you that story. Well, my dad, who has a great interest in agriculture, has always encouraged us children to be productive when it came to, providing food. And every holiday when we, went home to Jamaica, he would always get us to plant a fruit tree. And here you see the naseberry tree that I planted in our family home in Jamaica, under those lovely skies, which you could probably have done with today. However, my naseberry tree didn't actually do very well. It tended to be very indistinct, didn't really flourish. And then, in January of 2010, when I had just started negotiations with Wolverhampton for this post, I had a conversation with my father, and he said to me, something really important is going to happen in your life. He said, because your naseberry tree has suddenly sent up this sprout that has this little crown on the top. And there it is. And all through the months of negotiation, when I wasn't really in a position to say anything, my dad kept saying to me, he said, something's going on in your life, he said, because the naseberry tree, the sprout gets taller and the crown gets bigger. So here we are, the naseberry tree. Right, well, because naseberries, the growth of naseberries aren't really very obvious in any literature or on the web, I'm afraid the metaphorical representations that you will have throughout my presentation tonight is actually acorn to oak tree. But that's kind of a nice marrying together of the two places. Just before I actually get into the aims of the presentation, I would just like to bring it to your attention how actually involved the West Midlands and Wolverhampton have been in contributing to this whole area of organ donation and transplantation. Clearly, we have the biggest transplant unit on our doorstep in the Birmingham Queen Elizabeth Hospital. It's the biggest transplant unit in Europe. And we also have the organ donor register was actually the brainchild of a locally based family. The Coxes, Peter Cox died unfortunately in 1989, and his family followed his wish to donate his organs for transplantation. And the Coxes thought that there wasn't anywhere that Peter could actually have registered that particular wish. So they brought it to the attention of the government at the time that they thought they needed an organ donor register and that there might be other people who would be interested in registering their wishes for the use of their body after death. So in 1994, we got an organ donor register. And since records have been kept of that register from 1999, nearly 3,000 people have donated organs that were on the register. And the number of those organs have been close to 10,000. I'm very pleased to have in the audience tonight Rosemary Cox, Peter's mother, and I'd just like to pay an enormous tribute to your family for your forethought and initiative in this respect. And we mustn't forget either that we have Elizabeth Buggings, who was the chair of the West Midlands Strategic Health Authority, who while she was there actually led the organ donation task force, which reported in 2008. And reported recommendations to overhaul the whole of the donation and transplantation system to make it really fit for purpose. And I think Wolverhampton has scored another first tonight, actually, because I think I could be pretty safe in saying that this is the first inaugural lecture that has actually, certainly within the UK, that has actually had organ and tissue donation and transplantation as its primary objective. Now, organ transplantation and donation, of course, is not only about the transfer of organs. It's about the people that are involved. It's about the donor. It's about their family. It's about the waiting recipient. It's about their family. And it's very much about all the healthcare professionals and other agencies that support people in these difficult circumstances. So that is actually what my talk is about tonight. It's about the people that are involved. However, just a little health warning that because of the nature of the subject, it could be sad and it could be emotive. So, the aims then for my presentation. I'd like to share with you a little bit about how I actually became interested in this topic of organ and tissue donation. I'd like to share with you some of the issues and concerns of this particular field. I would like to share with you the theoretical perspective for dissonant loss that I developed as part of my PhD work, which provided an explanation of how bereaved relatives actually experience organ donation. And then, using examples from 4 other studies, and I'm trying to draw from the tissue work as well, and also work in transplantation, to give a flavor of how that original study, branched out and grew into a consistent program of research. And also along the way and at the end, I would like to highlight some of the impact of these studies. So, how did we start off? Well, the year is 1978. It was the year of shark shorts, when you just tore your shorts off and it was all raggedy at the end like a shark had ripped it with his teeth. And Chinese slippers, some of you might remember wearing those. And this is my girlfriend's yard in Jamaica. I was home on holiday. I was a registered nurse working in Canada at the time at the Princess Margaret Hospital. And it was right by this swimming pool that my friend Kay shared with me the fact that her sister Betsy, who had moved and was living in Florida, in Miami, had taken their little boy, Andrew, into hospital to have his tonsils removed. It was, in the days when everybody routinely had tonsils out. And Andrew had never come out of the anesthetic, and Betsy donated his organs for transplantation. He was 3 years old. And there was something about that story that stayed with me. I don't think I knew anything really about organ donation at the time. I probably thought, they took the organs out in the mortuary, or, I really can't remember now what I didn't know about organ donation. But I think it was this little lady that actually had the effect. Of course, she's rapidly heading towards middle age, but at the time, she was very much the same age as Andrew. And I wondered how Betsy had, whatever it had been involved, had been able to make that decision to donate the organs of her little boy, Andrew. Well, fast forward to about 1991, I was by now a nurse teacher at the Dorset and Salisbury School of Nursing and Midwifery. And it was Project 2000. Nursing education was just moving into the universities, and we were all being invited to upgrade our qualifications. And so I was thinking, looking around for a project, maybe I'd do an MSc, maybe a PhD. I had a good first degree, so there was options there. And I noticed going through the hospital at Poole one afternoon that there were these, the chair and secretary of this organization called the British Organ Donor Society that were coming to talk to the intensive care staff about their experience of being donor parents, and also to talk about this peer support group that they had set up for families that are involved in donation or transplantation. And I went along to the talk that afternoon, and it was really some kind of awakening, an epiphany, whatever it was. I knew that this was an area, having listened to what John and Margaret had said about their donation experience, that I had to look into. And you do, as one does, you go to the literature and see what is written. And really, there was, of course, the medical literature, a lot of molecular science as far as transplantation was concerned, but nothing really about the social processes and about the people that are involved in transplantation. So I thought that for my PhD, when I had finally got my questions, I wanted to look at what the experience of being a donor relative was all about. Now, if we just look then at what some of the issues are for us in this field, here we have, these are the numbers of deceased donors and transplants in the UK from April 2001 to March 2011. So that would be the last completed year. Unfortunately, when I was developing this talk, the statistics for this complete year weren't quite ready. But I think that you can see quite clearly what the problem is. We have an enormous list of people that are waiting for transplants. And in 2010-11, it was 7,800. And what I would say to you is, as you can see in the title, these are people that are on what we call an active waiting list. So they're well enough to have a transplant should an organ become available. There are another 3,000 people that are on that waiting list that will be what we call suspended. They being too ill, if an organ did come along, they wouldn't be well enough to have a transplant. So we could say that on any day of the week, there are about 10,000 people in the UK that are actually waiting for an organ transplant. And here we have the number of donors from deceased persons. And that's who I'm going to be talking to you about tonight. Living donation, we could have another whole session on that, but we'll be just dealing with people that have donated after death. And you can see that, we had just over 1,000 organ donors in between 2010-11, that year. So there's an enormous disparity between the number of donors, the number of transplants that become available from those donors, and also the people that are on the waiting list. So why do we have this problem? Well, interestingly, this is the front of the Times. Their front page, 30th of January of this year. And they talk about one of these problems. And that is that, I'd just like to read you this quote, because it says here that organ and tissue donation is widely regarded and officially in the Department of Health end-of-life strategy as being part of high-quality end-of-life and bereavement care. However, hospital staff are failing to make every opportunity count. So that is one of the problems we have in raising sufficient organs to meet this enormous disparity that we have. And the second reason, again, just in 12th of March this year, another headline in the Times, that organ transplant targets are thwarted by families who say no. Now, I really hate that headline. I think it seems to lay blame at the foot of families for not donating organs, where I think we should actually be trying to find out why it is that, in fact, they're declining to organ donation. But families are saying no. We know that generally across the United Kingdom, and I say generally because I think there's a recent realization that, in fact, some of our figures might be very inaccurate, but we know that generally about 40% of families that are asked about donation will refuse or decline, a word I prefer. And we know that that number actually rises to about 70% in British minority ethnic groups. So much of our work at the moment is about trying to understand why we have this declining rates. And these problems are not particularly associated only with the UK. We have 50,000 people across Europe who are waiting for organ transplants, and we have over 100,000 in America who are waiting. So I think countries generally across the world are battling with these issues. So what I would like to do now is to share with you that theoretical underpinning of my PhD work, which has driven, if you like, the program of research that has followed. And this, as I had mentioned before, was about the experiences of donor relatives. The sample of families that I talked to, there were 24 relatives of 16 organ donors. The age of the donors were from medium of 26 years, a range of 10 weeks to 56 years. So I had a little baby in that study that had donated organs, and the eldest lady was 56 years. So as you can see, a very relatively young age group. The number of days donors spent in hospital, there was a median of 4 days and a range of 1 to 21 days. So again, something to notice that these donors and families were spending very short periods in hospital and very intense and emotional time for them. And this was the model, if you like, of the theory that I came up with. And if we start from the left, working over to the right, there were 11 categories that seemed to describe the way that people experienced organ donation. And the first category was about recalling the last time that they had been with that relative. People often said, made some comment about the clothes they were wearing, the activities they were involved in, what their last conversation with that loved one had been. Informing, finding out that something's gone wrong, police coming to the door in the middle of the night, hospital phoning to say your relative has been brought in after a road traffic accident. And then hoping, actually going to the hospital and waiting to find out what is wrong, and having hopes and expectations that the person would be coming home. As we have seen, these were all relatively young people, so at that time there was no question that they were actually going to die. And then this is where, if you like, the organ donation experience actually starts with relatives becoming aware that things were going wrong and having their own personal realization of death. For instance, a wife said to me that, she had touched her husband's hand, and there was something about the quality of the skin that made her know that he wasn't going to be coming home. And then deciding about donation, so the confirmation of death, and then making donation decisions, what was going to be donated, and if they were going to donate, and what was going to be donated. And then parting, saying goodbye to the loved one, and leaving the intensive care unit where they'd had this very intense relationship with staff over a very short period of time, and asking, you know, what do I do now? And then coping, dealing with grief and donation. And what I found was that these experiences were experienced through this idea of conflict and resolution. Now, conflict was defined as the simultaneously opposing tendencies within the individual or environment that cause discord, dissonance, and the distress resulting from these instances. Now, this allowed me to go on and develop this theory of dissonant loss, and that is defined as a bereavement or loss that is characterized by a sense of uncertainty and psychological inconsistency. And here is, if you like, the pathway of that theory that leads us from the realization of death and the conflict and resolutions that take us right through to dealing with grief and donation. And what I'd like to do is to just share with you a little of the detail in some of these categories. I can't do all of them because of our time constraints, but I'd just like to give you a few examples from each of these categories. I'm not going to address the realization of death. So if we took the conflict of the confirmation of brainstem death, what families found difficult was actually equating the appearance of the ventilated person with somebody that was actually dead. And they also lacked knowledge about death certified by brainstem tests. People had heard of brain damage, but this was a whole new concept that they had to get their heads around. And the resolution to that conflict was some families chose not to see the person once death had been confirmed, having confidence, of course, in death certified by brainstem testing, and also post-donation viewing of the body. And I'll just let you have a read of this as one family's experience of how they viewed that post-donation body and the resolution that it created for them, having last seen that person in a hospital bed with a functioning body. Okay, so if we move on then to donation decisions, and once the conflict for families now was about, you know, are we going to donate and what are we going to donate? And the resolution was knowledge of the donor's wishes. If the donor was seen to be somebody who was particularly caring and sharing, so if they had those attributes, if the relative had had this very personal realization of death, and also the medical confirmation of death, and information about the donation operation, particularly that it was a proper surgical operation that was done, and it wasn't about just ripping out organs or stripping things out of people. So that was a great comfort to families to know that. And then it was about saying goodbye, and again, leaving a person who did not appear to be dead. They knew the body is functioning with ventilatory support, and that had to do with the aesthetic presentation of the body. And the resolution for many families was options and advice about saying goodbye. And the nurses sometimes on the ward would phone the family once the donation operation was complete, and that seemed to give them some sense of closure. But I'd just like to read you this quote, because I think this is really so important about the advice that's given to people about the options of saying goodbye. And this was the mother of the little baby, and this is what she said. She, the nurse, said to me, she said, "Do you want to hold him?" I said, "Oh, I don't know." And she said, "Many people that don't hold their babies regret it later on. Why don't you hold him?" And I said, "Oh, I don't know." And she reassured me that, it was the best thing to do. So I did, and I can't thank her enough. I was so glad I held him for that last time. Held him twice, actually, in the same night. I'm so glad that I did. I think she's right. I would have regretted not holding him for that last time. I felt so chuffed. I felt so proud. My baby. The final category was about dealing with grief and donation. And here, the conflict for some families was about coping with the affectional bonds for the part of the donor that lived on. Coming to terms with their donation decision, was it something that they now were still happy with? And also a lack of specialist bereavement support, often created, and information as well, created conflicts for these families. And the resolution to that was about focusing on the achievement of the donor, having information about the recipients and how that transplant had actually affected their lives, feeling of making a contribution to society, and knowing some good had come out of this very sudden, generally very sudden and awful death. Having specialist bereavement support. But above all else, what these families wanted was their donation to be recognized, to be valued, and not forgotten. And this was just to show you, during the course of my PhD, I won a travel scholarship that took me to America, and I was able to visit the Jackson Memorial Hospital in Miami and their donation and transplant services. And this granite stands in the walkway of the Jackson Memorial Hospital, so that anybody that enters that hospital has to pass this granite stone. And it not only serves as honoring, if you like, organ and tissue donors, but it's also, of course, an artifact for education. And Miami actually has one of the highest donating rates, certainly in the United States and across the world. We've done the PhD. We have a theoretical frame from now to grow. And here I am on that trip, having won actually my first competitive award, if you like, after my Department of Health nursing studentship. And that's the transplant coordinator and myself in the intensive care. The donor is in the bed right behind us, a young policeman. We were taking him down to theatres in the morning. And as you can see, the acorn has begun to open up. And the key outcomes from that was actually the chance to observe the American donation and transplantation systems and their relatives aftercare programs. And it also began, if you like, the inception of an international network. Now, the first selected study that I wanted to share with you, when I had done my PhD work, it was single interviews we'd carried out with these families, and I'd done that big survey with UK registered nurses. But what we didn't have and didn't know about was what happened to relatives over a period of time. How did the bereavement of our relatives who had donated organs actually unfold? So I was fortunate enough to be funded by the Community Fund to do a 3-year longitudinal study that we talked to 43 relatives of organ donors and interviewed them on 3 occasions over time. And the key outcomes from that study was that we found out that what was really, really important for families was developing this rapport with health professionals and the time, attention, and care. And my research fellow and I used this little acronym, TAC, tack it into your mind, that, this attention to their needs was key to donor relatives' understanding about donation and their decision-making. And also about the questions that they had. We found that people that had developed this rapport had far less questions over time than those who did not. And we found that unanimously people wanted information about the impact of donation on the lives of recipients, and that when they got that, it was actually, it was desired and appreciated. And bereavement support was very valued as well. Now, this was the team. For me, the growth here was this was the first time that I had actually put a research team together. And here we are on the day that we were celebrating our nice big award from the Community Fund. This is Corinne Marchant. She was transplant coordinator at the time, who was enormously supportive in helping us to get that study going. Sheila Payne, who was my PhD supervisor, exquisite and wonderful mentor, exemplar, and she has remained a great friend, and we've been involved in many projects since together. And this is John Evans, who was the person that I went to listen to in the intensive care that afternoon way back in 1991. And John was our sponsor for that project, and we worked through him and Body. So that was, for me, as I said, the growth there was actually putting this team together and carrying out the project. Well, of course, you not only want to do your work, but you want to bring all the young talent on board and expand the expertise in various fields. And I'm enormously proud of these 2 young ladies, Dr. Tracy Long-Sutol, who is with us here tonight, and Joanne Wells, who were both PhD students of mine. Tracy has gone on to win a very prestigious fellowship from the NIHR, and she's doing work with the tissue services and acts as a consultant to them. And Joe did work in corneal donation in the palliative care setting and is now down in Australia doing good work down there. So I'm sure that Tracy would agree with me that it's, tissue services sometimes don't have an enormous high profile. It's all the life-saving organs, but tissues really are just as important. And so what I would like to do is to just share with you a little bit about Jo's study and what she found looking at corneal donation within a palliative care setting. So that was exploring, and as you can see, we're beginning to grow, and the oak tree is branching out. And what she found was that it seemed her theory about corneal donation in the palliative care setting was one of shielding behavior. And she defined that as the desire to shield from harm all those affected by corneal donation process in the hospice setting. And there were 4 categories to her study. The first of that was about what professional stakeholders, what were they aware about donating corneas in that setting. And then there were other stakeholders. So there were the patients themselves, there were their relatives, there was the chaplains, the bereavement counselors, the transplant surgeons, all other stakeholders. So it was about their knowledge and what they brought to that encounter. And then there was this category of being, a question about whether corneal donation would actually impact the personhood of that deceased person. There was this idea, of course, of keeping the body whole. And it was also about the body being helpful. And again, I just wanted to share with you, because what Joe found was that, people that, were dying and had cancer often thought that, their bodies were rubbish, as they called it, and that it wasn't good for anything or anybody. So this is a quote from a patient. "It is good to know that I'm not useless, and even though the body is becoming crappy, I can still do something for someone else. That's a good feeling." And then it was about gatekeeping, so safeguarding patients and their families, preserving this palliative care philosophy that this should be a very tame and natural death without any massive medical or surgical intervention. And also what was very important here was the emotional bond that was formed between the health professionals and patients in that encounter. And emotional bonds were very important in people being able to open up and discuss corneal donation. And one of the things Joe found in this in the category of choosing, was that it should be a living choice. The difference between an intensive care donation and a donation in a hospice setting was that in the hospice setting, people knew they were going to die, so it should be them that are making the decisions about what happens to their bodies. Whereas an intensive care unit is usually an unexpected death, so the donation decision then usually falls to the family. And I just love this. This was a quote from a recipient that Joe interviewed. And this is what he said about losing his sight and then regaining it. And I'd say there's hope for my father here when it comes to the last sentence. "It is good to know, I only bought this flat for the view. Then one day I woke up and I couldn't see it anymore. The thought of never seeing the waves and changing colors was just devastating." And he becomes very tearful at this point. "I get upset remembering it." And then he had his corneal transplant. "I went from a man who was dependent on others back to my old self. I've even got a girlfriend now. Not bad for an 84-year-old. So I think that Joe's study, added enormously to our understanding of this field. The third study was now looking at a group of people that we hadn't addressed before, and these were the relatives that actually declined donation. And this was at a time when UK transplant was a subcommittee, if you like, of NHS blood and transplant, was becoming aware that the rates of declining in the United Kingdom were actually quite significant. So we were commissioned to actually look into this for them. And the key outcomes of that study were that I think one of the sort of really learning points was that we found that positive views of the family or donor in life did not actually mean that donation would take place. Other things seemed to impact it. And it was possibly it could have been one or many factors that actually converged in an aberrant fashion around that time of death. And it could have been things like, the timing, the request was made too early, the manner in which it's made, it wasn't sensitive enough. Families may have valued time with the individual or wanting to be there when they actually stopped breathing, and these things were not available to them. But above all was the desire to protect the body and keep it whole and intact. And a father, for instance, who was asked about the donation of his daughter, and he was a donor card carrier, he just he wanted her body to be kept intact and whole. And he said, well, what was the rationale for that? Because afterwards we actually had her cremated. But it was the whole way that encounter had been carried out that he hadn't made a decision that might have been different. He didn't realize, for instance, that the child's body would have to be opened and therefore for a post-mortem examination, and therefore he probably might have made a decision to donate organs. And then finally, I'd like to share with you now, we have expanded, the oak tree has grown a bit more. We have now moved into the transplantation side of things. And we were funded by the British Renal Society to explore the life world of 30 individuals who are waiting for a kidney transplant. And this was actually, there are quite a number of studies that have been done on people living with end-stage renal disease. But this was the first study, we think, internationally, that actually had the life world on a transplant waiting list as a primary objective. And what we found with this study was that we developed a theory around this, which was called seeking normality, that all these patients, all these individuals were trying to balance their lives in a way that they could remain hopeful for a transplant and also well enough so that if an opportunity came along to have a transplant, they would be ready. So it was about living with end-stage renal disease, dealing with the symptoms from those issues, dealing with the treatment regimes and its associated limitations. So, being on dialysis and having restrictions on diet and so on. And then over here, it was trying to live normal as life as possible, dealing with hoping and waiting. And what we found was that there were a number of factors that either constrained or influenced this ability to keep normality. And some of these were the health status of the individual. Ability to work was hugely important. The ability to continue with other interests, supportive family and social network, their approach to illness and waiting, financial issues important, and information and support from health professionals. Now, I suppose you realize that you have actually grown up when you are invited to come to the House of Lords and to share your observations and your opinion. And Tracy and I went along in February 2008 to share with the Lords our opinion about increasing the supply of donor organs within the European Union. And our husbands accompanied us on that trip, and you can see there Tracy and I in Westminster Hall. And as Linda has mentioned, I'll be going back there in next month to try and see what more we can actually do to raise consent to organ and tissue donation. And just to bring, if you like, all of this together for you, this video runs for about 10 minutes. It was, all the words are taken from an interview that I did with a father where he reflects on the donation of his son. And it was sent to Los Angeles last year and entered into the Shortcut Film Festival, where it won the award for top award for foreign documentary. What of the future? Well, clearly, I've got a strategy to deliver now, as well as carrying on with the work, the open donation work, and helping students, sharing with them all the knowledge and experiences that I have gained over the years. So, just in finishing, here are some of the lessons that I have learned. You need a sound theoretical frame. You need a mentor who is supportive and always encourages you to take the next step. And I would absolutely say that I found that in Sheila Payne. You need to build a knowledgeable, cohesive team who are supportive of each other and whom you trust, and who can be depended on to be constructively critical. And look for opportunities to share your work and expand your horizons, but only invest your energy in proposals that you actually have a good chance of winning. And finally, grow your students, and then you can welcome them on board as well-trained colleagues. Thank you, ladies and gentlemen, for your attention.